So I hope everyone had a good lunch. Feel free to keep doing what you're doing. I want to introduce our next session, Communicating and Educating More Effectively. A good benefit design is obviously not enough. It's vital to increase awareness and understanding of benefits among plan participants and to help them navigate through the health system. We'll first hear from Dr. Lisa Fitzpatrick, who will be speaking on building trust and improving patient engagement. Dr. Fitzpatrick is a board-certified infectious disease physician and medical epidemiologist. She's the founder and CEO of Grapevine Health, a digital health media company that she established to build trust and improve patient engagement among Medicaid patients through delivering culturally appropriate and relatable health information. After that, we will transition into our next panel discussion on how to help plan participants better understand and use their benefits. Dr. Fitzpatrick will be joined by our moderator, Dr. Rawlins from WellSpark, Teresa from Blue Cross Blue Shield Association, Pamela from the Business Group on Health, and as I turn the page here, there we go, Wayne Turner from the National Health Law Program. Dr. Fitzpatrick, it's all yours.
Good afternoon. I'm glad you're still here. It's very exciting. I'm really happy to be here, and I had the benefit of listening to the earlier panels, and so much of what was said resonates with me, but also with the work we do at Grapevine. So my job here today is to convince you, if you're not already convinced, that health literacy is the driver of everything. And it sounds obvious to some people, but the problem is we've had trouble getting traction with people prioritizing interventions for health literacy. So a lot of my talk is going to be story-based because the people we interact with in the community are what keep us going. Even in the face of a lot of no's and a lot of doubt and skepticism around why it's so important to communicate to people in plain language, but also why the messenger matters. So I'm going to be a little unconventional, which is pretty typical for me. If you have a question in the middle, I don't mind if you raise your hand because you need a clarification or you want to say something. Or if you want to just say amen, that's good too. Okay. Oh, I'm going the wrong way. This one? So I'm pushing which button? This one, okay. So why health literacy? You heard my bio. So I've done almost every job in healthcare, including being the chief medical officer at DC Medicaid, so a Medicaid state program. And all those roads actually led me back to this experience. This happened in 2007. I was working at CDC at the time, and I was in the community working on an event with 100 black men, and we were answering questions from the community. And a man who looks very much like this walked up to me, and he said, "How does someone like me access someone like you on a regular basis?" And the reason he's asking that question is because he had multiple doctors. He was on a lot of medication, but it was all very confusing to him. And he wanted to hear the message from someone who understood where he was coming from and who could also talk in plain language. So I've never forgotten this story because it really illustrates the impact of health literacy. And so if you look at all the different ways health literacy intersects with the work we're trying to do with community, with patients, in health policy, all roads lead to health literacy. Whether you're trying to understand why people aren't going to see a primary care provider. That statistic you heard earlier about being in a location where there's plentiful access, but people are not using the access available to them, even though they have health insurance. We see that right here in the DC area. A lot of it is linked to health literacy, which is also linked to fear, which is also linked to distrust. So that's why people are missing appointments or not going to visits. Medication adherence is a big one we hear about all the time. You probably have heard stories about why people either ration their medications or refuse to take medications. I hear a lot from people telling me that doctors are drug dealers. It's hard to hear, but when you have a conversation to understand why they think that, it's really about the optics, because our visit times are short. We often talk over people's heads, and then we write prescriptions. So hopefully you're getting a picture for why I think this is an imperative for us to really focus on and address. And then the obvious reasons, because it's expensive. This has been studied numerous times, and we know that health literacy costs the health system nearly $300 billion a year. And then here's some more granular information about the cost of health literacy. We talk a lot about avoidable emergency room visits. A lot of that is actually linked to health literacy, because people don't always know the difference between what's urgent or what's emergent, or if this rash needs to be evaluated right now. But when we talk to people, they help us understand why they think it's so important to sit in the emergency room versus going to a doctor. We also know among Medicaid enrollees, it's much more expensive if you have someone who has low health literacy. There are higher rates of hospitalizations, avoidable hospitalizations, ICU visits as a result of low health literacy. So these are the people we're trying to work with at Grapevine Health. And I'm sure I probably am preaching to the choir for any of you who are working with underserved communities, but also if you have a community that is culturally and philosophically similar to the Medicaid population, and I like to say a lot of the people who are commercially insured are 1 or 2 paychecks away from being insured by Medicaid. So what can we learn about the similarities that could help us translate to how we should be engaging them around not just all the other social drivers we like to talk about, but their understanding of health information and their health conditions. Health literacy is definitely linked to distrust. So many times, I have so many stories on the street with people telling me, well, I'm not going back to that doctor because I don't understand what she said. Or he talks down to me. Or they're not listening to me. All of these things are linked to health literacy. So these are the people we're trying to help. And how many of you have ever had a family member call you and say, what does this mean? Or send you a text message saying, can you please, go in my portal and what does that test mean? Like, am I dying or not? And here's an example. This is a real example. Someone sent me an email and she said, I had my colonoscopy, but do I have cancer or not? So when you look at it, the areas or the words I've highlighted, these are the words that were tripping her up. Precancerous adenomatous? That sounds pretty cancerous to me. So I had to explain to her what these words mean. But why aren't we doing a better job now that people have unprecedented access to their clinical records by going into MyChart or some of these healthcare portals? They get the information before their provider, their provider sees it, and then they're alarmed. 2 weeks ago, my friend who is being treated for breast cancer, she sent me a text with an image and said, can you help me interpret this? Like, do I have this thing or not? And I said, actually, that's not a test result. That's a procedure report. So people are confused by the information we're flooding them with, and we're not much help. So I've wanted to do something about this for a really long time. Has anybody seen a Dr. Lisa on the Street video? Well, I know Pam has. A couple people. So from the time the gentleman asked me how to find someone like me, I tried to figure out how you could scale access to plain language from trusted messengers. So the best I could do was to create a Jay Leno jaywalking type situation. And I've hired a videographer. We went out onto the street to talk to people. I think the first video was about the flu, very basic. What is the flu? How do you treat it? And what are the symptoms and so on? And it was really insightful. But what encouraged me was how much people wanted and appreciated an opportunity to talk to a doctor about excuse me, a very simple, ordinary topic. So I'm going to show you an example of that, since most of you have not seen Dr. Lisa on the street. Doctors often speak in a language that people don't understand. Has this ever happened to you?
Pretty much all the time.
Oh.
About mechanic set.
Not cooking food properly.
That's salmonella.
Well, that's no.
Okay.
And don't want one. I see everyone pushing it. They keep pushing it. And everyone keeps pushing it. I'm sick of corporate America pushing stuff on me.
Sean got some Pop-Tarts.
Yeah.
Okay, didn't you just tell me that we have to cut down our sugar?
I did.
And you're a diabetic, and you have Pop-Tarts and Fruit Loops.
Yeah.
These are the kidneys alone.
You said kidneys are lungs?
Kidney all alone.
So that's the kidney. This is the lung.
Our hospital with her one day, and she wanted to say she was pregnant, but she said, "Oh, I got a stomach ache," something like that. So it depends.
You go to the emergency room and get a physical. So do you have
Sometimes
yeah.
it all depends.
But how do you think we can get the message out to them?
The way you're talking to me now, each
Right.
one teach one and
Oh.
spread the news.
All right. I'm Dr. Lisa. I'll see you on the street. So we've learned a lot from talking to people on the street, and now I just want to share some of those insights before just leaving you with an understanding of what we're trying to do at Grapevine Health. So the first insight I want to share is that we overestimate what people know about their health. And so these are questions either me or other doctors on our team have gotten on the street. Do any of these surprise you? And I'll just wait. What do you think? Is there anything here you've never heard before? No, you've heard all these? A lot. You have. Well, not surprised, Doc. The one that surprised me the most, though, was this last one. Eating sugar shuts your immune system down for 5 hours. Y'all have heard that before? Okay, because I was like, where have I been? So this woman was a keynote speaker at a wellness conference. And this was in Atlanta. And she spoke with great authority. So when she said this, I thought, well, I'm an infectious disease doc. Must have missed class on that day. So I actually went to the literature to figure out what she was talking about. And I found a study from 1976 or somewhere in the 70s. And I think it was a Sentinel study identifying the association between immunity and sugar. And in this study, they tested the macrophages. Macrophages are a component of the immune system that are responsible for engulfing bacteria and foreign objects. And they tested the macrophages in mice. And what they found was after the mice got sugar, their immune systems, the immune response was sluggish for how long? 5 hours, which has become your immune system shuts down for 5 hours. And this is how the game of telephone happens. It's how health information travels on the grapevine. It's why patients would come into my office and say things like, I heard my herpes turned into AIDS. And what they heard was, if you have an ulcerative sexually transmitted infection, you might be at higher risk to get HIV. But what she heard was something completely different. And so the question is, how can we communicate this information to people in such a way that it's so understandable that they don't make these tragic mistakes like misunderstanding, not knowing what happened when they were admitted to the hospital because someone didn't communicate it in a way that was appropriate. So this is an ongoing education for us because we always hear different things. Was there anything else you wanted to know more about on this slide? Okay. The health messenger matters, and this one is a hard one, a hard insight, because especially among healthcare providers, we are very egotistical about our ability to communicate health information. And we believe that we are the best communicators of health information, but often these text messages I'm getting are translating an understanding they got from a healthcare provider, and they're confused. So when I've talked to healthcare providers about this, they say, well, we don't really have time because the visits are so short. There are a lot of administrative pressures, like how are you expecting us to communicate in plain language when people have so many questions? And that's a subject for another talk, but I think in general, we have to be intentional and humble about the way we communicate with people. Like, we're still smart people. We went to medical school. We're still smart if we don't talk in medical jargon. And it's harmful when we communicate in ways that people don't understand. And so what we're hearing from people is, well, I love that doctor talk. This is Dr. Fabian Sandoval. Some of you may know him. He is a brilliant communicator. He has a TV show, a health literacy TV show, Tu Salud Tu Familia. And he comes on the street frequently with us and talks to people in Spanish in certain parts of the city. I mean, that's the kind of engagement that's needed. And so people often ask, well, everybody can't go on the street, or, sure, you can touch, 10 or 15 people, but this is where the video and the text messaging comes in, which I'll tell you about in a second. But people also say we like getting this information from someone who looks like me and someone who understands where I come from. And the reason it's hard to hear is because when you look at the demographic mismatch between a lot of underserved communities and the people who are providing care, it feels like an impossibility. Because if there's a cultural mismatch, we can't fix that overnight. But there needs to be an awareness, again, humility, I use that word a lot, that we need to be humble about learning about how we should be helping people and communicating with them so that they get the information they need. And the last thing I'll say about this is during the pandemic, we were recommended to a well-known health system, national health system, because they had a subpopulation within their employee population that did not want to get vaccinated. And these are all either Spanish-speaking or Black people. So the reason they called us is because they thought we might be able to help this health system. So I had a conference call with their chief medical officer. And when I explained to him what we do, he basically said, well, we have 17,000 doctors. I mean, we've tried all sorts of education. You see the problem? Over and over and over again, it's this failure to recognize or to have the humility about the missed opportunity to relate information to people. And the final insight I'll share is related to how we're communicating with people. The healthcare system is woefully behind in reaching people where they want to get information. So we collected some data before I even started Grapevine Health. We were funded by the Commonwealth Fund to understand how people were using their smartphones, and even if they had access to a smartphone. And the take-home message is, except for 2 people, we talked to 300 people. Except for 2 people, everybody had a smartphone. And these are all Medicaid beneficiaries. So that was the first thing. We have to stop saying people don't have access to technology. They do. We have to innovate for the technology they have. The other thing we asked them was, show me what apps are on your phone. So you can see I've highlighted some of them here. Are there any other ones you think were on the phones that I don't have here? Well, this is before TikTok, but TikTok surely would have been one of them. Apps like Solitaire, so people were playing games. And I took this photo on the Metro, and this is in Washington, D.C., so I don't know how familiar you are with, how many of you are from the area? Oh, a lot of people. So if you've been on the Green Line, it's interesting to take the Green Line all the way to the end because you see the huge change, and it's only black people after Navy Yard. And this is when I took this picture because I was actually living in Southeast DC. And it was shocking to me. Every single person on the train was looking down at a smartphone. Where are we in healthcare? They weren't looking up health information. They were watching YouTube videos. And I know this because I started walking up and down the train. Because I could see, like, what are people doing? One lady was reading the Bible. You know, someone was playing solitaire, but mostly people were scrolling on social media. And in healthcare, we are afraid to engage with people on social media, but that's where, whether we like it or not, that's where people are getting their health information. So what about all this? So I think this education we get from the community is the gift that keeps on giving. And I realize I'm one person, and sure, I can speak in plain language and explain to people what spondylolisthesis is in a way they understand, but ultimately, there are a lot of doctors and healthcare providers across the country like me who are passionate about health literacy and who also are gifted at plain speak and feel like it's an imperative that we communicate to people in a way they understand. And so what we're trying to do with Grapevine Health now, we are adding doctors who, and they have to pass a test, by the way, because people reach out to us and say, we love what you're doing. Like, I want to be a Grapevine doctor. And I asked them to send me a video because I need to see that they won't use words like, and one of our doctors is guilty of this. We were on the street talking about colon cancer screening. And he said to someone, the gold standard for detecting colon cancer is a colonoscopy. So it happens because it's so easy for us to speak in medical jargon. But I want to know that people are capable of speaking in a way that relates to people's understanding and is basically plain. So over and over and over again, we hear from these doctors who want to participate, but then they fail the test because you have to be trained. You have to train yourself. You have to be intentional. So luckily, we have found some docs who are interested, and if you know other docs, send them our way. But the idea is to get them on the street along with video, and then we can digitize that because we can create messages that could either be sent via text message or however. Most of our customers are insurance companies. But after being here today, I realized there's a need among employers for this kind of thing as well. So I'm going to leave you with the Grapevine announcement video because Dr. Lisa on the street, I'm just one person. Grapevine shows the possibility of what we could do if we collaborate broadly with other healthcare providers and even other organizations who care about what we're trying to do with health literacy. Because all roads lead to, how many of you have I convinced that all roads lead to health literacy? Only a few of you. I haven't done my job. Let's see if the video can do it for you.
Do you know the difference between an HMO and a PPO?
No, not really.
Do you have health insurance?
I do not.
Why not?
Confusing. I don't know how to get
It's confusing. What's confusing about it? We all need health information we can trust.
Hello, Jay. You got a question?
That's why I started Grapevine Health. We've made it our mission.
Our mission
To take the fear and confusion
out of medicine and healthcare.
Higher than
You don't want to wait till you get my age to address your diabetes.
The easiest way to connect with people is to be really vulnerable.
Thank you so much for taking the time to talk to me.
My pleasure.
It takes a village.
I appreciate you passing along some life-saving information.
We'll see you out in the streets and right here on the Grapevine Health Channel.
Your source for trusted health information.
And that's all I have to say. So thank you very much. And I'm going to invite the rest of the panelists up now and our moderator.
What was the right answer for the colonoscopy? Yes.
Well,
what would you have said in the colonoscopy exam?
Instead of saying gold standard, the best way, as far as we know, the best way to find colon cancer is to do a colonoscopy. And what a colonoscopy is blah, 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 blah. And you'd be shocked at how many people actually don't know what a colonoscopy is. So, yeah, lots of different ways. I've also turned to writing jokes about this, so.
Oh, good. I'm glad this way. We have actually a wonderful panel today to talk about, I'm going to stand up, sorry, about benefits. The wonderful thing is we have two Waynes. So for me, it's easy. Wayne Turner. We have Teresa Money, we have Pam, and we have Dr. Lisa on the end. The really great thing about this is that, oh, I don't need oh, thank you, you can, thank you. The really great thing is that we have a group of people who have different perspectives and different stakeholders that they represent. So my hope is we really have some back and forth and controversy, actually, about how we answer these questions about benefits. It's nice to be hanging around, I say, with the pros from Dover, and it's really wonderful. Let me go ahead and start, and folks will let me know what time-wise. I know, and Becky, and for folks that are engaging us virtually, please send in questions you have, because we'll have time for questions in the room as well as questions virtually. Now, each of you provides a unique perspective and represents different and unique stakeholders. What strategies have your organizations found to help employees or beneficiaries or other stakeholders that you represent to best understand their benefits? And I'm going to start with Wayne here.
Sure. Thank you so much. And I really appreciate the opportunity to be here. And I really thank the Academy for just hosting this, but also just the ongoing work on health equity. You know, it's like it's so easy just to check a box and move on, but having the sustained effort and the tremendous resources are really valuable for advocates and those of us who work on these issues. So thank you for having me. Yeah, so my name is Wayne Turner. I'm with the National Health Law Program. So I'm a senior attorney, and the organization was founded over 50 years ago as a support center for legal services providers. And so we continue in that role in healthcare advocacy, policy, and also some litigation. And so so we still work with legal aid organizations across the country, but also work in the advocacy and policy space. And so a lot of our work is focusing on Medicaid. So again, we're focusing on healthcare for low income and underserved and neglected populations, but also looking at the Affordable Care Act coverage. And so we do a lot of work on essential health benefits. So those apply to the individual and small group plans, as well as the qualified health plans that are sold through the ACA marketplaces. So I also serve as a consumer representative to the National Association of Insurance Commissioners. And so in my role at NHELP and a role as an NAIC consumer representative, we're really trying to highlight what I see as the gulf between coverage and access, right? Because there's no access without coverage, but so often we see coverage without access. And so, so this is one of the main challenges. And thinking about storytelling, I was just thinking about a community meeting I was here attending a few years ago in Washington, D.C., when we were talking about child and maternal health and the benefits and how to spend grant money. This is Title V grant money. So it was a needs assessment meeting. Some 300 people from the community showed up at this meeting. It was mostly mothers and grandmothers, caregivers, caregivers to kids with special needs. And time again, these moms and these grandmothers would get up and talk about trying to access specialty care for their child and getting a voicemail box that was full, or not being able to contact the providers that they needed, and just being exasperated about that. They also talked about transportation, right? And so in the Medicaid program, non-emergency medical transportation is a Medicaid benefit. And there's also written into the Medicaid Act an affirmative obligation under federal law for state Medicaid programs to help people make appointments, to help access appointments for kids, the special benefits for children on Medicaid. And so all of these participants in this meeting were Medicaid beneficiaries, and they were all talking about benefits that were covered. A few months later, I was looking through the Medicaid managed care contracts, and I saw not only provider networks including specialty care, but also requirements on the managed care plans to provide care coordination and case management. Actually, 3 different tiers of case management that were required depending upon the complexity of the health needs of the child. And so not only was this a benefit that was on paper, but this is a benefit that we were already paying for, right? That we as DC taxpayers and the federal government were paying these managed care plans, big bucks to provide a service that people weren't accessing on the ground level. And so again, sometimes legal aid has to come in, and you have to go to a lawyer to try to fight for your health rights. But it shouldn't have to happen on that back end. It should happen on the front end. And I'm hoping that that's something that we can talk a bit more about. But I really thank you again for the opportunity.
Teresa?
So thank you for that. And so in my role, I work with our plans, our Blue Cross plans, to administer care management services, so case and disease management. So I'm glad you brought that up. And so we ensure that all of our plans across the country, it's a federal employee program, so we have our members in every state, and we work with the local plans that host our members, and we provide them with the program requirements and our expectations around member management. And there are different levels, because a member may opt for mailers, they may opt for more targeted interventions and communication, phone calls. So they dictate how they choose to engage. So we would like to have that variety of services that are offered to them, and we work with our plans. But ultimately, you have an expectation that they screen and enroll people, but members also have the option of calling in to receive those services if they need it. So it is really important that they have that. That is an essential part of the healthcare navigation, to be able to ensure that these members can gain access to the benefits, or if they're unable to find a provider, for example, to assist with that. So it is really important, and that is part of my role in working with our plans to ensure that that service is available.
Thank you, Pam.
Yeah, sure. So, hi everyone. I'm Pamela Rich. As was mentioned, I'm with Business Group on Health. Business Group on Health is actually just up the street. We're a nonprofit membership organization, and our members are large self-insured employers along with their health industry partners. And those that we primarily interface with among those large employers are the HR, benefit, and well-being leaders. And what we strive to do is help them with their most pressing health and well-being challenges through convening, enabling them to benchmark with one another, and also providing them with opportunities to learn from us through things like webinars, issue briefs, papers, and the various meetings that we hold throughout the year. So I am really fortunate to work for an organization that provides or offers surveys every year to our employer members. So I'm happy to share that we do have some data on the question that you asked about the most effective communication channels and how employers are getting information to employees. And according to our most recent employer-sponsored health and well-being survey, which we do every year in conjunction with Fidelity Investments, employers say that the most effective channel to getting information to employees is through email. And maybe that wouldn't surprise many of you, but when we look at the next layer of what's considered also very effective, it's much more of the interpersonal channels that Dr. Lisa was talking about earlier in her presentation. It's through ERGs or peer-to-peer networks within the employer, through managers. Managers have had a lot put on their plate over the past few years. Communication to employees about health benefits and well-being strategies is certainly one of them. But we also know from another survey we've done that communication does matter to employees. But we also see employers thinking about text messaging as well, to your point, and how that can be a very effective channel. What I'll contrast that information against is a survey we did a few years ago about who employees believe to be the most trusted sources of information about health and well-being topics, including their financial well-being. And the two that really rose to the top are experts, and then that's followed by their peers. So really it is those peers that matter a lot in terms of the dissemination of information. So you can see where those two different data sources align really around of utilizing those interpersonal methods of communication as effective levers.
Wonderful. Dr. Lisa, I'm going to pick on you, actually.
Oh, okay.
Because we just saw what you're doing, what your Grapevine is doing around literacy. And when I think about literacy, this is my problem, is literacy, can you talk and read the newspaper type thing for people that are on here that don't know what newspapers are? In the ancient time, there were things that you would get delivered to your house and you'd read about the news and the funnies and sports. The next level is health literacy. What's diabetes? What's hypertension? And the next level, which is graduate school, is health insurance literacy. What the heck is a copayment versus co-insurance? What does a deductible matter? So how do you work with those issues about literacy, health literacy, and then health insurance literacy? And as a former health insurance guy, I have to look up those things periodically as well. So it's hard to do.
Well, background literacy it's really important. But it doesn't necessarily, even though a lot of the literature shows that there is a correlation between background literacy and health literacy, this health literacy issue transcends even that. And, I include insurance literacy in health literacy. I think health literacy, to me, is an umbrella topic. Do you understand all the things you need? Do you have access to the information? But do you understand all the things you need to be healthy, whether it's about the food you need to eat, what you say to the doctor, how you use your insurance benefit? I think it all falls under health literacy. I think the best way to communicate this information is like Pam was saying, and it's hard to hear that, I know, for a lot of companies who have a lot of legacy solutions around communication. The operation it's working, it's going, and to disrupt that, it's like cost and time intensive. But in order to help people understand what they need to understand and how to use the information, you have to put it in places and give it to them in ways they can digest it. So that's not a complete answer to what to your question, but I just want to re-emphasize what Pam is saying about the need to respond. We can't say we don't know. Now we have data to help people. And then the final thing I'll say about health literacy as a topic is that it's often talked about as a deficit on the community member, the patient, or the beneficiary. It's really our responsibility. And we should be talking about how we're failing to give people the information through the channels they want to get it, or how they want to get it, or who they want to get it from. That's what's costing us almost $300 billion a year, our failure to figure out how to communicate the information.
Thank you. Let me jump a little. We've been talking a lot today about equity and health equity specifically. As we look at equity, how do each of your organizations get input and feedback on the benefits that are put in front of people to identify unmet needs of the populations that you serve? And we'll start at the end with you, of course.
Most of the intelligence we get is from talking directly to people and hearing their stories about their challenges. One day we encountered a young lady who asked us if we could help her get health insurance. And when we asked her, well, have you ever had health insurance? And she said, yeah, and she called out one of the local MCOs. And we said, well, what happened? She said, well, I lost my purse. So that was an opportunity for us to understand, like, people don't even understand what their health insurance benefit is. It's just that thing out there. She didn't connect the dots that even though she lost her purse, it doesn't mean that her benefits have gone away. And so I think listening to them and trying to get that information fed back to our customers, the health plans, I think is really important. But it's really up to the plans to decide they're going to act on the information.
Yeah, and I would say I can speak from the employer member perspective, and we know from our annual healthcare strategy survey that we do every summer and release in August that a substantial number of employers are seeking input in some shape or fashion from employees to identify disparities in accessibility, participation, experience, and outcomes. So I think that that's the really good news. How they do that, I think, is variable. Many employ surveys and may ask in that fashion. We know others are doing things like focus groups, listening sessions, town halls. And then another means of gaining input and feedback comes again from employee resource groups, or ERGs, which have become a really important mechanism of not just gaining input and feedback, but again, back to our conversation just a moment ago of pushing information out. So they not only serve as a sounding board for whether something will resonate, if the employer is missing the mark, what else needs to be done, but once there is a benefit, program, service, initiative in place, they can also be the channel to push that out to the specific groups across the organization for whom that information also might be super relevant. So I think that there's a variety of different ways. Some are even going a step further and are doing more intensive looks at employees' lives through things like journey mapping, and that really goes a step above and beyond. But I think it's variable. I would say the biggest challenge for employers, and I think this was brought up a little bit earlier this morning, is that what we have learned from experts, including experts who specifically work in the area of listening, is that your surveys communicate your priorities. And so you have to be very particular about what you are surveying on. And the more opportunities, again, this is what we've learned from experts, the more opportunities you provide for open-ended feedback, the more opportunities that you may need to respond to that specific feedback because it cannot or should not be ignored. And then that feedback loop. So not asking, and this was talked about this morning, not asking without having a plan in place to act on that information. And that's something that we talk quite a bit about with our members.
Isn't that why they don't ask, though? They don't want to know because they don't want the responsibility to act on it.
And it was even brought up in a conversation, again, from an expert at Georgetown who presented on this recently with us, of it's maybe generalized information that you don't want to know, but it also is specific information that you may be opening yourself up to that you must act. So if you're providing an open-ended survey and someone expresses suicidal ideation, how are you tracking back to that specific person if there's no identifier and now you have that info? So again, just as a part of our surveying and listening strategies, thinking very carefully through what the end goal is, what the action strategy will be, and how you will plan on responding to information should you receive it.
Same here, placing a strong emphasis on the community connection, and we survey our members every year. We conduct a Blue Health assessment, and so your points are well taken around being strategic around the questions that you ask. I mean, our assessment, it just kept growing, right? And then we would find that our members would become frustrated at the length of the survey and not complete it. So we had to make some modifications to kind of prioritize our initiatives and bake that into other surveys. So asking questions related to, we ask their race and ethnicity, we ask for any social issues that they may be encountering. And we also conduct focus groups with our membership to help to co-create solutions. We no longer make assumptions. That didn't work for us. So we work with our membership to address their healthcare concerns. And through that, we've been able to successfully kind of implement solutions that are needed by our members. So that is really helpful, but ultimately knowing their benefits, knowing what they have access to, it takes multiple channels. Our goal would be to get to text messaging, but there is a barrier there with access to telephone numbers, right? And emails. How many emails do you have? I have 6. How do you know it's the one that's not junk that they're not looking at, right? So that's a challenge in all of that in terms of trying to figure out the best way to engage with the members to share them all of this valuable information.
So, my organization, we work with legal aid, and so complaints, right? And so a lot of, and actually not a lot, I mean, for someone to make their way to a legal services provider or otherwise file a complaint, that's just a very small percentage of the people who are having problems accessing their health care. I think the Kaiser Family Foundation produced some data showing just a very small fraction of people actually file an appeal when they have a claim denial. And we're not even talking about prior authorization denials there. So, but complaints are an important piece because that's what regulators look at. State insurance regulators look at complaints. Federal government looks at complaints, and so complaints is an opportunity. And of course, Medicaid enrollees have due process rights. And so they have the right to a detailed notice. They have a right to referral to legal services, and they have the ability to access free legal services. So that's one piece. The second piece is my organization works with outreach and other kind of health advocacy organizations, and so right now we're in the middle of open enrollment. So sign up if you haven't. But open enrollment and doing that kind of community outreach is particularly important, especially now that we're part of undergoing this Medicaid unwinding process from the public health emergency. And so, having those trusted partners, those certified application counselors, those navigator programs that really have developed a trusting relationship with the communities that they serve. In addition to other kinds of health advocacy organizations like federally qualified health centers, that those kind of community-based groups have long-standing relationships and are generally looked at as trusted messengers and are engaging in many of these kind of like outreach and enrollment activities. To a more limited extent, some of these organizations are able to provide things like community health workers because enrollment will only help you enroll, right? It doesn't help you kind of navigate the complexities of care and figure out what's going on. And so, having a trusted partner to help people navigate this process can be really helpful. It's also a real challenge because I'm getting ads ads all the time for people like sign up for Obamacare, and it's like I know the difference between a junk insurance plan and a real insurance plan, or a broker who's trying to steer me towards a plan that they get the biggest commission on versus an impartial assister. And so it's hard to weed through a lot of that noise. But again, the longstanding community-based organizations are the ones who are doing this work on the ground right now. We saw the previous administration drastically cut the funding for those organizations. Biden-Harris administration has restored that funding and then some. So again, an important piece for reaching out to get those feedback loops from beneficiaries, from Medicaid enrollees, from people who are trying to access plans, so you can identify those problem spots, those unmet health needs. And just last thing, we use data too, right? And data is really important. And so looking at broader data and partnering with actuaries is a really an important piece of broader advocacy.
I want to delve into this a little bit deeper about what you talked around trusted partners. And I want to be real specific, because trusted partners can certainly help, or trusted advisors can certainly help with understanding health benefits. And I want to know specifically who those trusted partners are that you work with and recommend for your stakeholders to engage with. I know you started, but I want each of you to spend some time with that, because it's critically important.
Yeah, I mean, this isn't well, I mean, anybody can access through via healthcare.gov to find out what their ombuds programs are. If their state has an ombuds program, that's a great place. Also to find the actual funded navigator programs operating not only in your state but in your service area, so you can access that kind of enrollment help. And then for legal aid, there's different funding sources, and there's a myriad of different types of legal aid organizations. The Legal Services Corporation is the federal entity, and they have a good tracker. And then also go to the NAIC, National Association of Insurance Commissioners. They actually have really helpful resources on how to find your insurance commissioner and how to file complaints. And so and it's actually really user friendly. And I've been working with NAIC to help update their outreach materials so that it's kind of explains things. And, again, trying to go to that plain language so that it's understandable. So those are just some of the things. But I think people also they know their communities. It's the community. It's your community organizations that are often performing these functions. Sometimes not without getting paid for it, right? But
Teresa, for Blue Cross Blue Shield, who have you found your trusted partners to be able to engage people to better understand their insurance benefits?
So we heard some conversation about your contracts and making sure that as you're measuring programs that you have PGs in your contracts and leading key indicators, but you also want to be able to leverage those contracts to advance any initiatives that you have. So we have a telehealth contract, and we can leverage that. I mean, as they're already engaging with our members, as another opportunity to share information and to address any of the members' concerns. We have a care management programs, as I mentioned, case and disease managers that we make available, but we look at all of our contracts where we have providers nationally that are delivering services to our members, and we will ultimately leverage those as well, because these are physicians that are working with our members, and they trust physicians and nurses, and so that's kind of how we have been. These are different sources that we have relied upon throughout the years, and we have other tools where we've been sharing health information over the years, and they've come to trust that. But you kind of made a good point about all the noise out there. There's a real concern that you're afraid to click on something. You're afraid to answer the phone because you don't know who's on the other end. And it's a real challenge in trying to engage with our members when that problem continues to persist, right? So I'd just like to hear from anyone else as to how you kind of cut through that noise and so that there's some confidence in when I click on this email or when I answer this phone call that there's not something nefarious happening on the other end.
So you heard me say before that when we look at our data from a few years ago, employees rate experts and then their peers for physical and emotional health information as the most trusted. And as I was thinking about that and anticipating Dr. Lisa's presentation, it got me wondering about what the ingredients for trust were. And you talked a lot about similarities, right? Of someone who looks like me, someone who's from a similar background. And I was wondering if there were other ingredients beyond just that. And I remembered we had an expert come in and talk about trust a few years ago and offered a few additional aspects of what builds trust. And I want to try this out on you because I think it might be instrumental in thinking through why employees trust certain entities over others. So it was that relatedness that you talked about, the similarities, but this expert also offered positive past experiences, a sense of safety and ease, as well as proximity. And I think that could be physical or psychological, most likely. What do you think about that?
100%. Yeah. It's all embedded in the relatability, authenticity, humility.
Mm-hmm.
It's all of those things.
Yeah. And so if I relate that back to what partners of large employers that may be the most trusted, as you heard this morning, employers have many, many partners. Mm-hmm. What we hear quite a bit about these days among our membership is trying to help employees understand and access their benefits in an easier, frictionless way through the use of things like engagement platforms that pull everything together in a one-stop shop that they can self-service, or the use of advocacy navigators or concierge services that help employees do the work for them. But I think that maybe doesn't address the problem that we're focusing on today, which is if you teach a man to fish versus if you give a man a fish, right? Which is the advocacy, concierge, navigator programs. They're helping kind of work around the health literacy issue versus teaching that from the get-go.
Yeah, no, I'm with you.
Yeah.
Gosh, I could also give a 30-minute talk just on this topic. I love this topic because, I think it's obvious that trust is necessary, but the harder part is the measurement piece, how it looks so different depending on who you're talking to. But ultimately, we found these community organizations that have been talked about, the places that are already providing the social drivers related services, housing, food, transportation. The community knows those organizations, and they're underutilized as partners. So again, humility has to come into play because you have to be willing to work with them and pay them for their services to help reach people and bridge the gap. I mean, just honestly, people don't trust their health insurance company. And we've heard this over and over again. They're just trying to, we ask people why they don't follow the nurse advice line. Like most plans have a nurse advice line. It's one of their interventions to keep people out of the emergency room, but people bypass the information and they go anyway. So when we ask them why they go, they say because, well, those people are very condescending. And when we're talking to them, you can tell they're just asking you all these questions to try and find a reason for you not to go. And these are hard things to hear, but they're things we have to absorb and implement if we want to build trust. So I think there's a huge trust deficit in healthcare, but particularly among insurance companies, pharma, and we have to own it and figure out how to bridge the gap. I often tell this story about, I call it the banana story. Some of you may have heard this story. I know you've heard this story.
It's a good story.
Because we're obsessed with figuring out how to get people to trust us. And we were out in the community one day, and this woman is walking back and forth. She's not engaging, but you can tell she's like ear hustling, like she's listening to see what's going on. And then she disappears, and when I see her again, She's walking toward me with 2 bananas, one of which she's eating, and then she hands the other one to me and says, "I bought this for you." And I was really touched. And I put the banana in my pocket, and she said, "No, I want you to eat it." And I said, "Well, I'm busy right now, but this is the perfect kind of banana. There are no spots. I love it. I'm going to eat it later." And she said, "No, I want to watch you eat it now." Now, some of you are probably afraid for me right now. But you shouldn't be. I wasn't. And I said to her, "Well, why is it so important to you that I eat the banana now? Tell me and I'll take a bite." And she said, "I want to see if you trust us." So exactly, that was my reaction. Like, here I am trying to demonstrate that I'm trustworthy. And I wasn't thinking about it from her perspective, which is, do you see me as your equal? Are you going to treat me with dignity and respect? Am I just as good as you are? And so we have to remember how we make people feel. Like, healthcare is very transactional, and people can feel that. We're always asking for things and giving them orders. Go here, fill out this form, sit here, wait there. And that translates into engagement or lack of. So it's just, the trust can be very nebulous, but it's also very tangible if you really dial in and figure out what it would take. People trust people they know, and like their grandmothers and people who've had, hospital experiences. Those are the people they call. They don't call the doctor. They call their uncle who had a 2-week ICU stay and made it home. Like, what happened? Like, what was that about? And so until we are, again, my word, humble enough to figure out how to leverage those relationships and have some of these non-traditional partnerships, it'll be impossible for us to bridge trust broadly across the health system.
Thanks.
You can see I get on my soapbox about trust.
I'll tell you a personal story, and I'm going to shame myself, unfortunately, about trust. I'm a physician, as you know, and my wife is a nurse practitioner. When my father had a medical problem, I'm not going to talk about it because we're broadcasting things. He didn't come to his son, the doctor. He came to his daughter-in-law, the nurse practitioner, because she gave him much better answers that he wanted to hear than his son, the doctor. So trust is very important about this. So thank you. Let me pivot a little bit, and let me tell you a story. I've been doing a lot of work with employers over the last couple of years, just like Dr. Krista here. And one of the things I was trying to understand with employers is how to get people to understand and use benefits, which we're talking about today. And a large national employer, their HR department was very pleased. They put together this wonderful benefit plan that no one used. Now, what they said is, well, no one uses the benefit plan, so it must be that we're wonderful people and the employees and dependents are less wonderful people. I'll be diplomatic about what they really said. But part of the discussion is, yes, we develop great benefit plans, but how do we get people to use them effectively to optimize their health and well-being so that they actually get the outcomes that employers and other stakeholders want? And I'm going to actually start with you, Pamela, just to get an employer perspective about using benefits. How do you get people to use benefits they have?
Yeah, so in preparation for this particular question, I wanted to know, beyond just trust, why wouldn't someone use their benefits? And we don't have that information at the business group, but I was happy to find the 2023 workforce mindset study. I think I'm saying that correctly, from Alight, which looks at the mindset of employees and how they view their benefits and well-being initiatives. And what that study found was that although the majority, or at least half of employees, knew about the benefits that were afforded to them by their employer, there was a gap in utilization, and the top 2 reasons for that gap was lack of time to figure them out, and also just the complexity of those benefits. And I don't know that we need to belabor that complexity point. We heard from the panelists this morning, 40 different point solutions, and that, of course, is to offer a best-in-class benefits package to employees and meet their diverse needs. But it also means that employees likely aren't able to find what they need when they need it or where to even start. And then we've heard this sentiment reflected by employers within our membership, knowing that the benefits ecosystem can be very overwhelming. So how do you create and simplify a system of navigation so that employees can get what they need, again, when they need it? And I don't know that anyone has cracked the code on engagement, unfortunately, but I do think there is probably some promise to proactive outreach using things like claims data and other sort of information to anticipate when someone might need something and to intervene before they get lost. But I still think that this is an area that we're trying to ensure that many employees have access to these sort of navigation engagement platforms, things of that nature, so that they can utilize the benefits that they have.
I have thoughts on this. So why aren't people using their benefits? Number one, a lot of people are trying to use their benefit. They can't. I'm a good example. I need to get a physical exam. I mean, I had my mammogram earlier this year, but I also need a physical exam. I can't get an appointment until March, and I have like the best United Health group. So that's a problem. We have to find a way to enable access. One of the HEDIS measures for one of the companies we're working with is eye exams for people with diabetes. When we called people and asked them if they needed help getting an eye exam, a bunch of them said, we can't get an appointment. So I tasked someone on my team to call all the ophthalmology offices in Washington, D.C. And we heard, we don't take that insurance. We heard, well, what kind of insurance is it? Oh, it's Medicaid? Okay, well, the first available is 3 months from now. So there are a variety of reasons people don't use their benefits. But if you ask me to pick one, myself included, it's because you don't want to think about your health. When you think about your health, you usually think about something going wrong with it. And so these are just human issues. And so this is, bringing me back to why we try to focus on relatability as a value, because if you can make something interesting or relatable or something that connects with what people care about, then maybe they will pay attention. So to communicate about this set of benefits and why it's of value to you, to think about it before it becomes a problem, we're woefully inadequate at that.
Others?
Yeah, just to piggyback off of that, same issue, the Ghost Network, trying to get access to a provider. It's something that continues to evolve, and it's getting worse, it's not getting better. And we had a conversation at our table about that, and we shouldn't have to wait 3 months for an appointment. So we really shouldn't make any assumptions about the membership and the patient population as to why they're not seeking care. And to the point that you made, your health benefits are there for when you have a problem. That's the mindset. It's not, your business of sick care instead of health care. People are not thinking, I need to get a preventive visit. Because some people are afraid to go because they don't want to hear, every time I go, they tell me something, right?
They're looking for something.
They're looking for something.
I went to the doctor. Wasn't that a quote on your presentation? Yeah.
So how do you crack that? How do you break through that? And I love what you said about, that community connection and engagement. Before COVID happened, we were exploring having these non-traditional health advocates to go into barbershops and hair salons, to meet the people where they are, to kind of promote health and wellness visits and things of that nature. But then COVID happened and all the hair salons and barbershops, closed down. So that is something that we continue to explore and see that as an opportunity because, at a minimum, preventive care, the preventive visits, preventive care utilization, we have measures that we report out on those, and those numbers are not great. Part of it is people are reluctant to utilize their benefits because they don't want to know what they don't want to hear, or they just you can't get an appointment. So there's a lot of work to be done to kind of close those gaps, as we heard a lot about, and we heard from Dr. Singleton that, I mean, that's a priority that we, continue to try to address and work through to ensure that our members have access to the care that they need.
Can I just add one thing, though? I think we also have to think about the experience. So if I have to wait 3 months to get an appointment, what happens when I actually get there? Are people going to be rude to me?
Yes.
Are they going to be condescending? I mean, do I need to tell them I'm a doctor so I can get good service? We don't pay enough attention to that, and I think payers need to find ways to evaluate the practices that are enrolled, because this comes up all the time when we talk to people about maternal health. Like, everybody's talking about maternal health disparities. But to me, the number one reason people don't go is because the experience.
Yeah.
So if you're promising, okay, we do all these things to engage you, and then you get them linked, and then they have a terrible experience, guess what? They're not going back.
And what I will say about that, and you just triggered something for me, and we are hearing, because of the poor experience of having to wait so long, of employers trying to work around that by offering things like virtual primary care. If you can't get in to an in-person physician, can you offer virtual primary care as an alternative? And then I heard of an employer recently who's now started mystery shopping to see what the member experience, employee experience is like.
Great.
And not just trying to figure out if she can get into a doctor, but actually going to the doctor themselves. This person said she went to multiple primary care to see if she was getting consistent messaging and results back. And to be fair, we're not seeing a ton of that mystery shopping, but I do think there is increasing recognition about the importance of that experience and standing in the shoes of what an employer, their family member, and what they're experiencing.
Yeah, and actually in the Medicaid managed care space, we're seeing some regulatory authority now for states to conduct secret shopper surveys. Not so much on the client experience at the provider level, unfortunately, but certainly on these ghost networks. Two things that haven't been mentioned yet, and I would be remiss if I were up here and did not talk about them. First is prior authorization, right? So we heard about that this morning. Like people literally having to jump through hoops, almost literally, figuratively jumping through flaming hoops to get access to services. We've seen the number of benefits and services subject to prior auth grow exponentially within the past 10 years, whereas before it was usually reserved for kind of like the higher cost services. And so also regarding prior authorization, why are certain services like substance use disorder treatment, why is that subject to prior authorization at all? If you are having an issue with substance use and you want to seek treatment, why do you have to go through hoops to get permission for that? So, so when we're talking about plan benefit design, let's talk about what kinds of benefits can we exempt from prior authorization so that we can fast track people into those important benefits and services. The second thing I want to talk about is obviously cost sharing more broadly, but I want to talk about co-insurance. So co-insurance, in my view, is just inherently discriminatory. But so we have two prongs with co-insurance. One is you're paying a percentage of the cost of the service, but you don't know percentage of percentage of what, right? And so there's that transparency issue. Oh, you have to pay 40% of the cost of that drug or of that service. Well, 40% of what? It's like how are you supposed to calculate what your outlay is going to be? But the second is, I think that co-insurance is inherently discriminatory because it places the burden of health care on the people who need it the most, right? So you're paying a percentage of the service instead of, and we're out, like there's a bunch of actuaries in here, right? So it's like, instead of spreading the risk across your population, you're saying, oh, the people who have the high needs they have to pay a big chunk of that service. And so who is that affecting? The people with disabilities, the people with chronic conditions, the people who need those services are having to pay the lion's share for those services, a percentage, and again, of God knows what cost. So again, we saw Montana a number of years ago eliminate co-insurance as inherently discriminatory for a brief period of time, and now they've reinstated it. But I think that that's really something that when we're talking about health equity, right? Because equity is about people with significant health needs, people with chronic conditions, people of color, people who are who have been otherwise neglected or underserved by the health system, trying to access the system, and so forcing them to pay the lion's share of benefit they need does not advance equity. Thank you.
Let me ask a question. Excuse me. Let me ask a question around after we've got all these fabulous benefits and people are using all these fabulous benefits, medical costs may go up. Is this a problem or not? And I'll ask the health plan expert and the employer expert about that.
Not if the use is appropriate.
It's a good trend.
Okay, all right. Fair. Now, I know we have about 10 minutes left, I think, so I want to open it up for questions inside the room first, and if folks in video land, internet land, want to ask questions, please submit them so we can get them answered by this group of panelists.
While we're waiting, can I just say, I know a lot of what we've said here is, it sounds very negative and sort of Debbie Downer, but there is hope, and I think the message for actuaries or people who are looking at the numbers is that now you have some information to help you interrogate the numbers you're looking at and ask a different set of questions. So at face value, it may look like this is going to cost a lot of money, but what could be the outcost of taking a risk on a solution, something you've heard here today, or a different way of looking at why those numbers are the way they are? Because I think it's not just like numbers on a spreadsheet. These are people. And so is there a way for you to incorporate some of this qualitative information into your deliberations? And also, you carry a lot of influence, especially with payers. And are there recommendations you could make or questions you could offer, probes you could, enter into the conversation to make these decision makers think in a different way about how to help people, because it has to be more than about just the money.
Amen. You got one.
Hold on a second. The microphone will be coming.
Hi, Yekaterina Bogush again. Again, another Medicaid bias question, sorry. I was wondering if you could speak a little bit more about languages as a barrier to access, and again, what could be done in a more structured approach in terms of the benefit design and requiring, for example, for a certain locality, if an employer operates in a certain state or concentrated in a certain state or county, and there are certain demographically prevalent languages. In Medicaid, they use it all the time. They have certain threshold. For example, if there are, again, certain number of individuals, a percentage above this, they require all the managed care organizations to offer materials, to offer network access, again, even bilingual case management staff, anything like that that you can comment on in the employer space.
I would just say that for large multi-state, multinational employers, many of them are offering their benefits information and communication materials in multiple languages, down to any local dialects if they're global as well. I think it was commented earlier that there's a lot of attention that needs to be paid to that to make sure that you're getting it right. But I would say that it's happening with languages. I would pile on to my answer, though, and say that I think it's also important to think about imagery as well in your communication materials, and also ensuring that those are reflective of the populations that you are serving, and also incorporate cultural nuances and variations.
I'd like to echo that. Representation matters, and so you need to be able to see yourself and know that these benefits and these services are for you. So same, we provide our materials in different languages and ensure that all of our member-facing communications reflect the community.
All right, hi. So I imagine after the question of how do I access care, the next question is how much does it cost? So what changes need to be implemented by the insurer or providers on making prices more transparent before the person gets the bill from the doctor's office?
Well, I can speak from the perspective of large employers, and many of them will have tools in place that can help employees estimate the cost of care before they get treatment, as well as not only estimate cost of care, but to navigate to high quality providers as well and look at costs associated with that. I think there's been a lot of misperceptions in the past that higher costs equal higher quality. So lots of education related to when you're providing price information to also ensure that you're having a conversation related to quality, and that higher costs not always equal higher quality.
Right, same, and we also publish scenarios so someone would understand or can kind of get a framework of what they can expect in terms of their out-of-pocket. So if you're going in, if you're having a baby, if you're going in for knee surgery, just having those scenarios out there so that the member can kind of have an idea of what they can expect in terms of cost and utilization. So that's been particularly helpful. In addition to those, transparency tools at the service level.
Yeah, and also navigators, concierge services, advocates will also play a role in the price conversation.
The transparency issue that you brought up is critically important. If you went to the Five Guys, I think it's downstairs here, and said, I'd like a hamburger. They said, okay. So how much does it cost? Well, I'm not sure. Do you have the special Five Guys hamburger plan in network? Or are you in there and it'd be somewhere between $70 and $10, and it would be somewhat annoying if you only had $12.50 in your wallet or your pocketbook. So I think the transparency issue that a number of people are getting involved in, especially on the hospital side and the pharmaceutical side, become really important to help people understand the issue about what's my financial responsibility, copayment, coinsurance, deductible, and all. It's a really great question. Other questions from inside?
So my question was actually, we were pairing each other, because I was going to ask the question of both my FEP colleague as well as from my fellow employer about the consumer now, the patient, the beneficiary, the consumer. It's like buying a car, and you want to go to get a car, you want to see all the pieces and parts. And so, again, just this morning on my cab ride over here, listening to my fellow employees be very, very vocal that now it's open season in the federal government and they don't understand the price pieces. And so, to everyone's point, how willing are you all to make that as a priority? Try to get your carriers to put these transparency points out there in scenarios that make sense, like what Wayne was just saying. And as you build them with our actuarial colleagues here, maybe consider behavioral economics to think through, because sometimes people will opt into something and sometimes they want to opt out, but it's not always universal. So I was curious your thoughts, my blue friend and my employer friend.
Something to definitely build upon to ensure that those scenarios make sense, right? And it begins with working with the members to understand where that additional information is needed and to not make assumptions. We would just make things up, like, oh, well, we know people are going to get pregnant. They may have questions about that, or someone may have we would say, oh, well, let's throw in a surgery in there. But instead of making assumptions, let's kind of reach back to our members and co-create, again, with our members to understand what type of, detailed information they need as it relates to expected costs, and then pushing that out to the member. They shouldn't have to pull it, right? Making it accessible. And oftentimes, a lot of this information gets buried. So we have to constantly go into our healthcare tools and member-facing communications to see how visible and how prominently displayed this information is. So something we will definitely be exploring.
We got an earful.
Oh.
About our plan comparison tool.
Plan comparison.
And they gave us an earful. And
Okay.
I'm sitting back laughing my head off because I'm like, I've been trying to tell people just because you put it on the website.
It's not enough.
Subtle
Yeah.
that they can click through. So again, to Dr. Lisa's point, I played the game. I looked last night and I put in my zip code in Atlanta, and it spit back the 6 plans that I could look at. Then I got to click on brochure. Then I got to click on these other pieces of it. And when you're in crisis, you're not looking for all those clicks.
Right.
And then I had to think through my own personal scenario. So I'm going to be vulnerable. I looked to my husband and I said, okay, it's about to be open season. Are there any particular health issues you're anticipating? And he named one, and then trying to find out how much it would cost.
He couldn't find it.
And I'm allegedly highly educated, and I was having trouble.
Wow.
And I was spending an hour and a half just on one element, and I knew he has this much of a trigger button, and he wasn't going to do it. But I think about what would be like for someone who does not have that luxury.
Right.
If you walk in the shoes of someone else, you don't understand.
And that's why I said taking it back to the member. And that mystery shopping, that term that I heard earlier, something that we started doing that because, on all the equity discussion and work, mental health, we were looking at mental health. And I'm like, oh, let me go out there and find our information on mental health. And 2 clicks in, which is supposed to be, that's our rule, 2 clicks in, you should be able to find it. No. Like 6, 7 clicks later, embedded, buried, someone who's probably already frustrated, overwhelmed with the care delivery system. This shouldn't be the experience that we're hearing about, like, right? That's this experience. So we started there, and then also in maternity, but definitely sounds like there's a room for opportunity in other areas. That work will continue. So thank you for that.
If I could speak to this, we talked especially earlier this morning about the power dynamics, the relationships, employer, employee, medical provider and patient, insurance plan versus enrollee or beneficiary. There is a disproportionality that's built into that relationship, right? I mean, it's very intimidating. The one time that a beneficiary, that a patient has any power in that relationship is the moment of plan selection, right? That's the only power, the only opportunity for power. Now in Medicaid, there's a federal rule that if you're required to enroll in managed care plan, you have to have at least 2 plans to choose from. Now, in the federal marketplace, we see plan overload, choice overload, when there's too many choices and all the plans kind of look the same. But having meaningful difference between the plans and having the actual comparator tools and then the transparency to figure out what's in the formulary, what does the tiering structure mean, what is the cost sharing? I mean, having that information not be 10 clicks away, I mean, that's so important. But let me just also say that's important, especially for people who are sophisticated buyers, right? So people with chronic illness, people who are caregivers, right? Caregivers are like they know what drugs they need for the person that they're taking care of. They know what providers they want. They know what specialists they want, and so they're searching for those pieces. And so being able to have systems in place so that those purchasers, those shoppers, can have the information they need to make the best choices. But then also the kind of comparators, for conditions, so that people can kind of like think, well, what if I do get sick, or what if my family, if we do have a baby, that those calculators can happen. But that's such an important moment, and I think that enrollment and giving patients the power during that enrollment period is important. Which brings us back to health literacy, right? It's all about health literacy. So anyway.
That compounds the issue. So you're talking about people who are, savvy, right?
Right.
And then you get to someone who you layer health, literacy on top of that, and so they're completely lost. So I can see how, that frustration can persist.
So all roads lead back to
All
health
roads
literacy.
lead back to literacy.
I know we're over time, and I apologize for the folks who are viewing this and haven't had the chance to get their questions answered. But I really want to thank our panelists, who, as I said, were the pros from Dover. So thank you so very much.
And we're now going to have a break until 2:05.